Good morning.
Good morning, everybody. Thank you very much. Thank you, Stano. This is an optical revolution. We have the ophthalmic arterial pressure control, so the perfusion pressure will be controlling our infusion. We will know exactly, and you will see in your screen which is the perfusion pressure right now. You see, if we move the bottle up and down, you will see that the perfusion...
Andre, we'll begin with you.
Usually four. The
Four people.
anesthesia guy, nurse, and the assistant and the surgeon.
The nurse.
Usually
One nurse, but anesthesiologists are in the war.
In the war, yeah.
They stay in the war.
Even though they want to go for a walk every now and often.
But
so we ask them to stay inside in the room.
But something happens? Nothing happens, no? Nothing ever happens.
No.
Spanish?
Yeah, I think the four, with the anesthetist going from one theater to the other at times, but usually four maximum.
And how many nurses?
One dry
nurse,
one
only.
unscrubbed, and the scrubbed is the fellow who assists us. So.
And who gives the instruments? Your assistant?
Yeah.
Assistant.
Yeah.
Kazuaki?
Yes, and standard system in Japan is we have the four. The one and the surgeon, and one assistant, the doctor, and the scrub nurse and the circulator.
You have a scrub nurse, and you have...
Yes.
And anesthesiologist too? No, you don't have
No.
anesthesiologist. Two nurses, but no anesthesiologist. Kirk?
The standard would be four anesthesiologists, so always a scrub nurse and a circulating nurse, and then the surgeon. And then, of course, in a training program, you would have the assistant, instead of being the scrub nurse, would be a resident or a fellow.
I just want to make one comment regarding, so as Kirk indicated, you have a surgical tech and you have an assistant. But I think now with the new machines, especially, for example, with Constellation, it makes it a lot easier so that the person who circulates in the room does not need to be as much trained.
Yeah.
Because everything is mainly done by the scrub, putting the gas, laser, everything, so it makes it a lot easier. And maybe down the road, the machines become advanced enough that you may not need anybody pre-trained, that the machine, you can actually, the machine tells you how to set it up.
Kudos.
Yes, we switch again to the...
Yes, we are coming back to live surgery, Stano. Can we go back to
Tommaso
the operating room? We are back in there now.
He's beginning the vitrectomy.
Okay, we're moving on.
Can you explain also the screen? We are seeing some diagram on the screen, or some line.
On the screen you have the infusion pressure. If we move up and down the bottle 5 centimeters, you will see that the infusion pressure increases, of course, because the arterial pressure remains the same in the meantime. And you want to make sure that we are in the green Judy 5 centimetri. You see that right now we're in the green area of the diagram to your left, which means that perfusion pressure is within acceptable limits, over 30 or 40 millimeters of mercury. While if you go up with the bottle 10 centimeters, you will see that the line goes in the yellow and then in a red field, which means you are under-perfusing the eye, given its blood pressure, his blood pressure. So go back to where we were, giù la boccia dove era prima, so that we go back in the green area of the chart and we feel safer. So we now did the anterior vitrectomy and we take a look at the retina. And in a second we'll be doing an OCT just to make sure that we mettiamo il basso.
He's a young surgeon with a good future.
So, Tommaso, does this take into account the blood pressure as well?
Of course, this is what it counts. We have a second armband that measures the pressure, and it communicates, and it communicates Wi-Fi with our instruments. And this is when we can calculate to the formula that we explained yesterday exactly what the perfusion pressure is. I hope you have a good view. XY a little is lower.
You're
You're a little bit off-centered.
Am I? Sorry.
You're measuring the brachial artery blood pressure, and assuming that that's the pressure that correlates in the eye, which isn't always.
I'm calculating. There are formulas to do it. And I'm calculating based on systolic and diastolic pressure what the pressure is for real in the arteria, in the ophthalmic artery. There are formulas that can be used in the glaucoma specialists know very well, and this is what we're doing right now.
Thomas, can't you lower the magnification of the...
How about this? Is this better?
It's better, of course.
So this is a twin action cutter. So the port is always open and it cuts really very well. This is thick blood in here as well as the vitreous, and it really works very well, very well. So I will remove this peripheral vitreous, and in a moment we'll be removing blood from the surface of the macula and see what the macula looks like with the intraoperative OCT, which is very handy in this very specific case, because this is when you can't do it preoperatively, but you may be willing to do some peeling unless you don't know if you don't perform it. So just to make sure that we do only what is necessary and nothing more, we'll be performing this. So I would actually, posso avere un chart per favore?
So I think we are done with the satellite and we are back to auditorium. Thank you.
Forceps. We all have an extra tray for that, for the non-disposable ones.
Quick question, I just skipped the long one. So patch and shield and antibiotics at the end of the surgery? Anybody does different than that? Some antibiotics in the surface and patch and shield, okay?
The question is, I think, how much the antibiotic we give afterwards does anything.
That's coming. So first, when do you see the patient for the first time? D0, the same day, the day after, or how do you follow up, Kirk?
Almost always the patient's seen the next day.
The next day.
Yes, and I see a patient the next day.
Next day?
Next day morning, yeah.
Next day?
Next day.
Next day. So we in France we changed. So we asked the patient to wait a few hours and we checked the same day. And we looked if it changed something. It doesn't change because many people coming from far, they prefer to go home. But still the trend is next day. So post-operative treatment. So typical, how many days, what? Because I think there is no real agreement to what to give to this patient in a modern day. Andre?
Just in case for one extra week. That's
1 week only?
1 week.
What?
1 week only.
What do you give them?
Eye drops.
Which one?
Antibiotics and some steroids.
Steroids and antibiotics. Manish?
We give for a month tapering, steroid and antibiotics,
Andre.
and for the first week
Kudos.
give dilating
Kudos.
drops, cyclopentolate.
Yes, Stano.
Okay, only one minute with
Go ahead.
OCT in real time.
So I think